Hello students, in this lecture for Introduction to Medicine, communication skills section of that course, we're going to talk about communicating risk, responding to emotions, and breaking bad news. Three very important aspects of medical communication. So let's get started here. First of all, we've got a table of the types of physician-patient relationships. There are a lot of different ways to kind of slice this up. This one is in terms of physician control and patient control, and then we have low and high. So when there is, for example, high physician control and low patient control, you get a paternalistic relationship, which medicine has been working on fixing for many years now. On the other hand, if there is low physician control and high patient control, you get a consumeristic relationship where the patient is in the driver's seat and the physician has much less power. The ideal relationship, of course, is mutuality. And we've got a little bit more detail here. In paternalism, of course, the doctor sets the agenda and goals. The doctor uses the language he or she is familiar with, biomedical language, and the doctor even may try to act in the patient's best interests. However, the doctor does not find out what the patient actually wants. There's an unequal footing. Interestingly enough, this may be a mutually agreed upon relationship. The patient might just say, okay, doc, you just make the best choice and I don't really want to be involved in it. You're the expert and I'm the non-expert, and I'm giving you power to kind of run the show. In a consumeristic relationship, it's kind of the opposite. The patient is the one that sets the goals and agenda, and the doctor is more of a consultant who follows the patient's demands. In the end, the patient's values prevail, for better or for worse. Obviously, in mutuality, there's an equal footing, shared decision-making. If there's low physician and low patient control, which is kind of hard to imagine, then you don't get very far. There's little or no progress. For consent to be informed consent, a patient must be, and then how would you answer that? Think about how you would finish that sentence. Just think about it for a second. Informed consent, what is it? For consent to be informed consent, a patient must be, one, aware of the risks, and then the benefits and uncertainty associated with a choice or treatment. So risks, benefits, and uncertainty associated with a choice or treatment. And we should also add that that includes the risks, benefits, and uncertainty associated with foregoing a treatment also. So either doing this treatment or not doing it. There are risks both ways, there are benefits both ways, and there is uncertainty both ways. There are a few hazards when you're communicating about risk. One is simply that the doctor must interpret the most recent data accurately. And so hopefully the doctors can do that, but there are cases when doctors do not. Poor health numeracy, and this is for both patients and doctors. So you've probably heard of literacy, the ability to read and write. Numeracy is your ability to use numbers well. And if we're honest, sometimes patients might have poor arithmetic or numeracy skills, and even doctors sometimes. I've had doctors struggle with how much to prescribe based on if it's a child or an adult. Not because they don't know, but because they're trying to convert a child's portion to an adult's dose or vice versa, and they do it incorrectly. Also, uncertainty about the future or about what might happen because of a treatment affects people in different ways. The doctor, the patient's children, or the patient's parents, and the insurance company, everybody has a stake in this person's health. and that uncertainty influences how people communicate. Also, our cognitive biases can lead to misinterpretations. We think that we're communicating clearly, but other people have different worldviews, different biases, different ways of thinking, and that can skew what they hear. Not necessarily on purpose, but it does happen. And strong emotions can also cloud our judgment and make us react in certain ways. A few comments here from Paling that I thought were helpful. The ways doctors communicate risk can affect a patient's perception of risk. That's kind of interesting, isn't it? That the way that the doctor communicates influences how the patient perceives that risk. It's also recommended that you supplement verbal explanations with numerical data. Don't just say it, give someone a number. Use absolute numbers. We'll talk about this in a minute. State the odds from a positive and a negative perspective, right? 9 out of 10 people recover from this. 1 out of 10 people do not recover from this. Using visual aids whenever possible, and we can imagine why that might be helpful. And then make sure the patient's informed consent is based on information, not just data. I think information here they mean by data that they've understood and processed. A few recommendations. So we've mentioned using natural frequencies versus percentages. Actually, we haven't done that yet. So natural frequencies, like for example, 1 in 10 instead of 10%. 2 in 10 instead of 20%. Using absolute risk versus relative risk, we'll talk about that in a minute. Framing information in a balanced manner, so not being too far like an alarmist or minimizing it, neither minimizing it nor making it out to be more than it is. Making the information personal whenever possible, and then using graphical and pictorial material. And graphical and pictorial material are important because some educators say that some people are visual learners, some are more auditory learners, and some people just understand pictures better than words. Another thing is sometimes just simply language barriers. People understand pictures perhaps better than words because either they're not very competent in the language or it's a second language. There are a variety of reasons why pictures help. Absolute versus relative risk. What does that mean? So let's give an example. Say the absolute risk of developing a disease is 4 in 100 in non-smokers. Say the relative risk of the disease is increased by 50% in smokers. What is the absolute risk for smokers developing the disease? It sounds complicated, right? So the risk is 4 in 100 for non-smokers, but the relative risk of the disease is increased by 50% in smokers. What does that mean? Well, let's look. So the 50% relates to 4. So the absolute increase in the risk is 50% of 4, which is 2. So the absolute risk of smokers developing this disease is 6 in 10. So absolute risk is about the total number of, it's about the total. Relative risk is the change in this number, the change in this number here. So increasing by 50%, well, 50% of 4 is only 2 people. But if you say the relative risk of the disease is increased by 50% in smokers, it sounds like there's a gigantic jump in the number of people who are at risk. So instead of using words like 50% increase in smokers, you should just say, look, 4 in 100 people get this disease. But if you're a smoker, it moves up to 6 in 100. 4 in 100, 6 in 100. So keeping this number the same is important. Absolute versus relative risk. Let's try one more. Say men have a 2 in 20 risk of developing a certain disease by the time they reach the age of 60. Then say research shows that a new treatment reduces the relative risk of getting this disease by 50%. What is the absolute risk reduction? So if the relative risk reduction is 50%, that means, all right, instead of a 2 in 20 risk, you just reduce that by 50%. Now it's a 1 in 20 chance. So by saying, wow, 50%, that sounds like a gigantic change. But in fact, it just reduces it from 2 in 20 to 1 in 20. Yes, 50% of 2 is 1. So this means that the absolute risk is reduced from 2 in 20 to 1 in 20. So we need to be careful with our language and careful with numbers, because using numbers in certain ways can skew people's opinions. Let's look at this one, for example. Which one sounds better? Let's try this one. We'll call it A. Your risk is now 2 in 20. A new treatment reduces the risk of getting this disease by 50%. All right. Or, your risk is now 2 in 20. A new treatment reduces the risk of getting this disease to 1 in 20. Well, which one sounds better? Wow, well, this one sounds pretty amazing because of this big number, 50%, right? Whereas this one says exactly the same information, but simply uses 2 in 20 and 1 in 20. So you can see how even though these are equal mathematically, the way that you use numbers can really make one sound good and one sound not as good. Even if patients understand both descriptions, relative risk sounds better and could unduly influence the patient's decision in this case. All right, what do patients want when we're talking about risk and about dangers? Patients want honest, accurate information, including the risk, and they want hope. We've already mentioned this a bit, but why would graphical or pictorial information help? There's a saying in English, a picture is worth 1,000 words. So sometimes all of our words can't say what one picture can say. It also helps people who have a low level of literacy or numeracy, and it just somehow speaks to our brain in a different way, and I'm sure that psychologists can tell us more about that. This is an example of some kind of like pictorial information, you might say. This is 1,000 women right here pictured in this box, 1,000 women. And then there are 2 highlighted areas there. The green highlight here said the odds for a 39-year-old woman of producing a child with Down syndrome or other chromosome abnormality, 12 out of 1,000. So they've highlighted these 12 women here, and you can see that picture. And then the red ones there, odds of a woman having a miscarriage as a result of amniocentesis, 4 out of 1,000. So you can see here that this pictorial information can help the woman see, okay, 4 out of 1,000, what does that really mean? And here's a picture of it. 12 out of 1,000, what does that really mean? Here it is. I've got another example here. This is for a treatment for weakened bones. And this is from this website right here, which you're welcome to take a look at later if you want. Let me show a picture of it here. So there's a medication, and it's trying to show the benefits and downsides. So on the benefits side here, they have this nice picture, and you can see without the medication, and then what are your chances of having a fracture? So they have, 60 did not get a fracture, 40 got a fracture. And then with the medication, then they show the change that this medication can make. So yes, some people still get a fracture. There is the risk of that, but the risk of getting a fracture is reduced by this certain number here. I think it's 16, if I'm correct. So you can see this pictorial information can show to what extent this medicine should help. Of course, on this side, we have the downsides, side effects, and all of that, which, people should know about. They need to know what the side effects are, what the risks are, and the cost. And then the patient finally gets to choose, what would you like to do based on this information? Some more pictorial information here about getting mammograms. And I believe that you can use this website here, Health Decision, to generate interesting diagrams like this one, pictorial information. You might want to try to check it out yourself. The following is what we call an option grid. And an option grid is a way of kind of anticipating patient questions and answering those questions step by step. In this case, the woman is trying to decide vaginal delivery or C-section. And an option grid kind of like breaks down common patient questions. And actually, there are more questions that I didn't include on this slide. For example, what are the risks to my baby? And then vaginal delivery. Of 100 babies who are born after slow labor, up to 5% have an abnormal APGAR score, a test to check the baby's well-being, 4% get their shoulder stuck, 1% need a tube. And then C-section, right? Of 100 babies, so the same number, you always want to use the same number, 6% have an abnormal APGAR score, 1% get cut during delivery, but most do not need treatment, 2% need a tube. Fewer than 1, less than 1% get a serious infection in their blood. So, if a woman's trying to decide, she wants to know about the risks to her baby, the risks to the mother, etc., etc. And it helps the patient kind of look in an organized way at what this involves. Here's another one, and this is for stopping a ventilator. So there's maybe an elderly relative that is on a ventilator, and then it kind of goes through the questions that patients might have. What actually is it? What does it involve? You or your representative will decide to stop the ventilator. You or your representative will decide to stay on the ventilator. This decision can be changed if needed. How long will the patient live? Everybody wants to know that. Is this the same as suicide? What are the risks? All of that. And so when people are trying to make hard decisions, difficult decisions, an option grid is a way of giving them kind of the most important information in an organized fashion. All right, let's think about emotions. So the bottom line is when doctors respond to patient emotions, there are better health results. That's important to know. And hopefully all doctors are interested in better health results. A doctor named Balint in 1957 coined the phrase, the doctor as the drug. This does not mean that you don't need to use drugs or use medicine. What they meant by that was that the doctor's responses to patient emotion influence recovery. It doesn't substitute for medicine. It also means that all diseases are at least partly psychological. And that's why people use the word illness, because illness is not just the pain or discomfort, but it's the person's interpretation of it. And therefore, it should be treated with emotion as well as biomedical skill. How much emotion the doctor should share is debated, but communication models recommend it. So, how to what extent do you respond to emotion? There's some gray area there, and you need to use your own kind of best judgment on that. But yes, there should be some response. The extent is a little bit more blurry, though, about how much you should. Responding to emotions empathetically helps because patients talk more, providing more information, right? And if you have more information, you can make better decisions, better diagnoses. Responding to emotions also encourages patients what's called self-efficacy, which is the belief that they can do something about their condition. So the belief that they're not out of control, but there's some hope. They have some control over their situation. And as a result, they might actively participate in their own recovery, which is great. And a therapeutic relationship aids in recovery, knowing that someone cares about you. That actually helps us. And it's important to develop this skill of responding to emotions. Some research has shown that empathy tends to decrease over the course of medical school, which is a sad thing. Many times medical students, you start medical school because you want to help people, because you are empathetic, but then, you get your brain filled with all sorts of biomedical facts and information, and sometimes empathy is tamped down or lost. And so it's important to maintain your empathy even in the midst of, learning a lot more about medicine. All right, breaking bad news. This is a big one, an important one. Here is a recommended basic structure for sharing bad news. First, establish the patient's current knowledge and willingness to receive bad news. So what do they already know about this situation? And where are they at? Are they able to receive it right now? Issue a warning shot. So, warn them somehow that bad news is coming. Make a direct, simple statement. So don't make it complicated, just say it. And then address the patient's agenda. So not the doctor's agenda, the patient's agenda in terms of feelings and concerns. Then it's the doctor's turn to give professional information. There are 3 basic styles of sharing bad news: the blunt style, the forecasting style, and the stalling style. The blunt style is where the doctor shares bad news quickly within 30 seconds. Just kind of get it over with. The second style, the forecasting style, the bad news is shared in stages within the first 2 minutes of conversation. In the stalling style, bad news is shared indirectly with more medical terminology, and actual sharing of news is delayed more than 2 minutes. So stalling, as the word implies, you wait and perhaps wait a long time. Generally, the second style, the forecasting style, is seen as best. I have had some students say that if they were a patient, they would prefer the blunt style. They just want to hear the bad news quickly. However, most say that the forecasting style is best, sharing within 2 minutes. All right. We're going to watch a video now. It's from this website, or this YouTube link here. And as you watch, I just want you to think about the stages, right? So we learned about these stages back here: establishing the patient's current knowledge, the warning shot, the direct simple statement, all of these things. And so look for stages during this conversation. Think about, how did the doctor introduce a stage or transition from one to the next? How does the doctor then respond to emotions and consider the personal needs of this patient? Now, please keep in mind that these are actors. This is not a real encounter. So, of course, there is emotion involved. There's the woman is, they're sharing bad news. So, of course, it's not a fun situation, but it's not a real encounter in the end. Keep that in mind. All right, let's watch this and look for the stages and how emotions are considered.
Flores.
Hello, doctor.
How are you? So I've scheduled this meeting for us today to discuss the results of your breast biopsy, but I've actually given my pager and my cell phone to my nurse practitioner so that we don't get interrupted.
Okay.
Are you alone or did you come with someone?
No, my children had to work today, so I'm by myself.
Okay. So how are you doing?
I still get tired, and I get dizzy if I get too tired. I've got some knee problems, and yesterday I had some nausea. Better today. I think it's probably mostly because of the blood count, the anemia.
Okay.
So I think I'm okay.
How about any anxiety or depression?
Well, I'm really worried about the test. I have a lump, so I'm afraid. I don't know about that test they did with the needle.
Have these symptoms affected your life in general, your ability to complete your housework?
Well, I've cut back my volunteering at the nursing home, but I still babysit my grandchildren.
Okay, so my clinic and I can help you with all those symptoms. We'll go over that, at the end of this meeting and in the next couple of weeks. Before we go over the results of the breast biopsy, I would like to ask you one more question. How do you handle medical knowledge? Would you like all the details of your treatment? In my family, my mother would defer to her children, especially me. How do you handle medical knowledge?
Oh, you'll have to tell me. I want to know everything.
Okay, all right. So, Mrs. Flores, I'm afraid I don't have very good news for you today. The breast biopsy revealed that you have an invasive form of breast cancer. I'm sorry. I wish I had better news for you.
How can I have breast cancer? I make all my checkups. I have all my mammograms. I don't understand.
Well, unfortunately, despite routine checkups, cancer can occur in anyone.
How long have I had it?
It's very hard to tell, but you probably have had this for several months.
No one in my family has ever had cancer, except my husband. Could I have caught it from him?
No, cancer's not like a cold. It's uncertain why some people get cancer and others don't. Tell me about your husband.
He died of colon cancer. I nursed him.
Sorry to hear that.
So, I've seen how cancer can eat you up. It's ugly.
I know this comes as a shock to you.
I don't want to be in pain like he was.
My clinic and I, we're going to support you through this, and we're going to guarantee that we address your pain and all the symptoms that you're having. We're also going to be available for your family, okay? I'm glad you told me how you're feeling, because now I know where you're coming from. The next step is for you to be meeting with a medical oncologist. This is the cancer doctor and the general surgeon. Most likely they'll recommend the following, either to remove part or your entire breast. The goal of this surgery is to remove the cancer. This is going to be followed by radiation therapy and chemotherapy, and the goal is to make sure that we kill any remaining cancer cells that could be present after the surgery. I think we should focus on keeping you comfortable.
Am I going to lose my hair? Am I going to have to wear a diaper? My children are going to have to take care of me.
Yeah.
Am I going to die, doctor?
No, you still have many options available. In fact, I hope the best for you, okay?
I don't want to be in pain like my husband was.
My clinic and I are going to help with any symptoms you may have, including pain. I can help you with all these things. These are all issues that will arise In fact, I'm a part of a team. In my team is a social worker. A social worker is available to you if you have any financial questions or issues. They're also available to you and your family in the event that you can no longer take care of yourself. They can provide services. And I have a great nurse specialist. She is very skilled in pain management and control of all your symptoms. She's also available for refills. And lastly, my chaplain, he can provide prayer or just basic counseling for you. Are you interested in any of these services?
I don't know, not now.
Okay. Here's a tissue. You know, I can't imagine how you're feeling, but we're here to support you and we want to provide you with the best medical care for you. We will support you in any way that we can, no matter what happens. Let's plan to meet February 1st. It's on a Tuesday at 9 a.m. So in the next couple of weeks, can you write down any questions that you may have for myself, the medical oncology team? Can you tell me in your own words what I have just said?
I have breast cancer. You're going to make an appointment for me with the cancer doctor to talk about treatment. But I'm going to get better. But I'm afraid. I'm afraid of what it's going to do to me.
I wish the best for you. You still have many options available, and we hope that we can cure this, okay? And what I understand is that you want to remain as independent as possible. You don't want to be a burden to your family. I can help you with all that. Here is my contact information for you. It has my number and the numbers of all of the people that I just talked to you about. And I have written down the date also of that meeting. Okay, would you like for me to explain any of this to your family?
Yeah,
Okay.
I'll bring my daughter. Okay.
All right. Again, I'm hoping the best for you, and no matter what happens, we're here for you. Okay? All right. Let's talk about your pain.
Okay.
All right. Tell me when it did start.
All right, so that was the end of that video. If you couldn't hear it very well, I'd encourage you to just use the YouTube link and watch it. So let's think about the stages. She used some nice staging. She used the forecasting style because it was right around the 2-minute mark that she delivered the actual bad news. And if you listen carefully to the video, you'll notice how she transitioned from one point to the next. Responding to emotions and considering the personal needs, you can see her there not jumping into the biomedical language, but letting the patient kind of get out her emotions and her fears and all of that. She does provide medical information, finally. When a patient is that agitated, it's not really clear if they'll retain all of it, but still she had the patient repeat back at least the most important things. In this video, it's the same actors again, but this time it's what not to do. So this is a bad encounter, what not to do. Think about what stages are missing, and then what other mistakes that the doctor makes during this encounter. You should also think about how the doctor responds to emotions and provides medical information. All right, so let's go ahead and listen to this one. It's much shorter this time.
Hello, ma'am.
Oh, doctor.
Miss Flores?
Yes.
So what's your body been telling you?
Well, I get very tired. I get some dizziness when I get overly tired. I have a lump. I'm scared. I want to know what the results of the test were.
Well, the reason we've been doing these tests, the CBC, the Comprehensive Metabolic Panel, the mammogram, let's get right down to it. Mrs. Flores, you have invasive breast cancer. It's metastatic to your lymph nodes. It's estrogen receptor positive, which is a good thing because you will respond to hormonal therapy.
What? I can't have cancer. No one in my family has cancer. Are you sure?
The next step will be for me to send you or for you to meet with a medical oncology team and a general surgery. They will probably recommend a mastectomy, a lumpectomy, and this will be followed by radiation therapy and chemotherapy. Do you have any questions? Have I gone too fast?
Oh, I didn't understand. All I heard was breast cancer.
Yes, sorry. You have a tumor, a growth. It's serious in that it can spread and it can grow pretty quickly. So it's been very insidious. Any more questions?
How can I have breast cancer? I kept all my mammogram schedule. I kept my checkups.
So your cancer has been very insidious. Was undetectable at stage 1, and breast cancer is very prevalent in the Hispanic population. You know what I need for you to do is just to remain strong.
I have breast cancer.
Yes, I know. That's the way nature is. I think I'm just going to refer to the medical oncology team at this point. But you know, Mrs. Flores, I know you can bounce right back from this. You're very active.
Am I dying?
No, you're not dying. You have plenty of treatment options available. In fact, I'm sending you to the best medical oncologist in town. I guarantee you're going to be fine.
I'm scared, doctor.
Uh, you're going to be fine. There's plenty of cancer survivors everywhere. In fact, my Aunt Marie, she was diagnosed with breast cancer and she is doing fine.
I don't want to be in pain like my husband was.
Like I said, you're going to be all right. I know just how you feel.
I've seen what cancer can do to you. It eats you up. My husband died of colon cancer.
So you know what the harsh treatments that are going to arise and the issues. I'm available to help you. Why don't I set up a meeting with you in a couple of months, say 6 months?
I have breast cancer.
I'm sorry, yes. I'm going to call in my nurse practitioner, Bonnie, and she'll be available to answer any questions. You can take your time. Here's some tissue if you need some. Let me go call her now. Here. Okay? I'll see you in a couple months. Bonnie.
All right, so what mistakes did the doctor make? I think another question is what mistakes didn't the doctor make? Just lots of mistakes there, but using a lot of confusing medical terms, not responding to the patient's emotions, making promises she can't keep, right? I guarantee that you'll recover. There's no guarantee. And sitting above the patient, not turning off her cell phone, all of those things kind of combined made this a kind of a horrible visit, a horrible encounter. And you can probably think of other ways as well that doctor communicated very poorly Telling the patient just to be strong, you'll be fine, rather than being sensitive to the patient's emotions. All of those are problematic. All right, that wraps up our lecture for now. Here are some resources if you want to look at them. And that is it.